Hello, everyone. I'm Ron Rolfing, and I'm the Preferred Vendor Coordinator here at ACAP. And I'd like to welcome you to our latest ACAP Vendor Education Series webinar presented by Freespira. As you may know, ACAP is a national trade association which represents not-for-profit safety net health plans. Collectively, ACAP plans serve more than 20 million enrollees through Medicaid, Medicare, marketplaces, and other public health coverage programs. Our presenters today are Mark Rakowski, Chief Operating Officer at Children's Community Health Plan, and Robert Cuyler, Chief Clinical Officer at Freespira. And they will be presenting the webinar, Unlocking Telehealth Solutions for Panic Disorder and PTSD Care Management, an ACAP member case study. But before I turn it over, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's call, and we'll post the slide deck recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. And of course, during the call, you can ask a question at any time. You can do this by clicking on the Q&A icon at the bottom of your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now, I'd like to pass it over to Mark and Robert.
Thank you. It's a pleasure to be with everyone this afternoon. And we're going to be giving you kind of a tour of Children's Community Health Plan and our collaboration with CCHP in offering an innovative new treatment for several really important mental health conditions. Mark, do you want to introduce yourself and tell us a little about yourself?
Sure. Thanks, Bob. I'm Mark Rakowski. I'm the Chief Operating Officer of Children's Community Health Plan. We're located here in Milwaukee, Wisconsin. We'll look at in a second at our service area, but we are affiliated with Children's Hospital of Wisconsin. I've been at Children's almost 22 years, and I've been with our health plan since we started it back in 2006. Born and raised in Milwaukee. I apologize if there's any Phoenix Suns fans on the call, but Bucks in 6, so we're really excited here in Milwaukee.
Thank you. And I'm Bob Cuyler. I'm a clinical psychologist by background. I have been affiliated with Freespira for about 5.5 years and use it in my clinical practice, as well as presenting information about Freespira in forums like this. Kind of my job to digest and communicate all the scientific evidence associated with these conditions and with our intervention. And we're really happy to kind of share our collaborative story with you this afternoon. I'm going to give you a little overview of what we're going to talk about today. Mark will start by giving us kind of a sketch of CCHP and their health plan and the services that they provide in their community. I'm going to be talking about these really important conditions, panic-related conditions and post-traumatic stress disorder, and to really talk about new treatment approaches, of which Freespira is a really important addition to the clinical tool set for people who work with these conditions. I'll tell you a little about the company, why we do what we do. Then we're going to talk about how this partnership between CCHP and Freespira evolved. And then we'll share with you some of the results from our first 6 months of collaborative operation, and then plenty of time for discussion and questions. Mark, tell us about CCHP.
So as I mentioned, we're based in Milwaukee, Wisconsin. We are affiliated with Children's Hospital of Wisconsin, but by no means do we cover just children. You see here our service area in eastern Wisconsin. We have really 3 lines of business. All 3 of them are part of the Freespira partnership. So we've been in the Medicaid program in Wisconsin since our inception in 2006. We cover a little over 150,000 lives. About 60% of those are kids. The other 40% are adults. All 28 counties that you see kind of colored here, red, dark blue, light blue, are our Medicaid service area. Eastern Wisconsin. We've also got a foster care program, a very innovative partnership with the state to cover kids in out-of-home care just in southeastern Wisconsin in 6 counties, about 2,800 kids. And again, several of them are impacted by panic disorders, post-traumatic stress disorder, by virtue of the situation that they're in. So they're certainly going to benefit from this program. And then in 2017, we started offering commercial coverage called Together with CCHP. This is our marketplace plan. We cover about 16,000 total lives in that program, and mainly adults. About 90% are adults in that plan. So again, all of them available for this program, and we'll share a little bit more information about the specifics that we've seen. So like all of you, there are behavioral health challenges for our members. Looking at our data, about 67%, 2/3 of our high-cost members have a behavioral health-related diagnosis. So these aren't members who have only behavioral health conditions. They have medical conditions, medical complications, both acute and chronic. But behavioral health often underlies a lot of what's going on with those members. As we look at our Medicaid population, depression is the 3rd highest cost diagnosis within our population, behind pregnancy and newborns. So it's moms, it's kids, and then depression comes next, which is, I think, a surprise for a lot of our staff and a lot of individuals that we share this information with. And specific to our adolescent population, depression is the most prevalent inpatient diagnosis for ages 13 to 17. Not surprising, depression and anxiety can often occur together. So while we've been really focused on depression as a program that we offer care coordination for, we haven't looked that closely up until now at anxiety and those related conditions. About 44% of our inpatient readmissions within 30 days are behavioral health related. The state has an incentive plan for us. The state really focuses on readmission rates, and behavioral health is one of the main drivers of that. And then as we look at our emergency department utilization, I think we all struggle with high utilization, with services that seem to be primary care treatable or non-emergent. And while behavioral health isn't a top reason for that ED use, chest pain, shortness of breath are often very common diagnoses for those emergency department visits that, as we're going to talk about, may be signs of panic disorders. So maybe undiagnosed populations that we're going to focus on. As we look a little bit at the programming that we've offered, we do have that depression case management program. We have newsletters. We have preventive reminders. We offer case management for high-risk members. We have a behavioral health case management team that works with our members. But often those services are one-on-one. They're not they're really difficult members to engage. And I think that's one of the reasons that the Freespira program really was something we wanted to look deeper at, because we know members in particular with mental health, substance abuse are hard to engage. They're hard to get into treatment. There's often members who leave treatment early. There's relapses, and we were just struggling to find better solutions for those members. Can advance the slide. COVID has obviously changed telehealth at all of our health plans, right? And so as we looked at our office visits, pre-COVID, post-COVID, we saw a huge increase in telehealth. Very honestly, we had very little utilization of telehealth before the pandemic. Less than 0.5% of our office visits were virtual. And in the months the months following the pandemic, that increased to 45% from March through the end of the year. 45% of our office visits were telehealth. Behavioral health, even more dramatic. We had a significantly higher behavioral health utilization rate for telehealth. About 2.2% of our visits pre-pandemic were virtual. It's about 4.5 times what our office visit rate was, but still very low. That peaked at 71% post-pandemic. Now, by the end of the year, as we look at the fourth quarter, things have changed a little bit. Office visits in the fourth quarter were around 11% telehealth, but behavioral health was still high at around 43%. We also have looked at the breakdown of those behavioral health visits by race and ethnicity. And we see a much higher utilization rate from our Black and Hispanic members of behavioral health visits virtually versus in person. I think about 43% of the visits for Black and Hispanics are virtual, while about 35% for our white members. What you don't see in that is that the white members still have a much higher actual utilization rate overall, about 3 times higher. They're getting those services. So our Black, Hispanic populations in particular are not getting the access to service that other members are. And that's, again, one of the reasons that we wanted to look at some alternatives.
You know, Mark, I've been involved in behavioral telemedicine for the past 20 years, and it was always this emerging trend that was always about to happen. And then a year and a half ago, myself and all of my colleagues underwent this. I have to tell you that I've never seen anything anywhere close to it, that there was a conversion within about 3 or 4 weeks of office services now being delivered by tele. What we're seeing in terms of national trends really mirrors what you just talked about, that a lot of people are going back, as makes great sense, to in-person visits with their physicians in general medicine, because obviously on tele, we can't palpate a spleen or look very comfortably into ears and eyes. But tele, because it really involves this kind of face-to-face communication when we're talking about, mental health visits, it really lends itself. So we're really expecting to see this continued use of technology. And as we talk, in a couple of minutes about Freespira, we'll be talking about how we use virtual visits and tele as part of our delivery system, which we think really has some important advantages in terms of improving access to care. I'm going to start by telling you a little bit about these conditions that most people find a bit surprising. So as Mark was talking about, I think that we're really recognizing the really significant impact overall of mental health conditions on whole body health, whole person health. And depression tends to get really the most attention in that mix. But because really the nature of the conditions that we treat, we really pay a lot of attention to what really are kind of unknown aspects of panic-related conditions, panic disorder and PTSD. And one of the most fascinating things that we've run across is when you look at how do health conditions affect people's ability to live their ordinary lives. There was a study that was done by the World Health Organization, published a couple of years ago, that use a metric that they call days out of role. And that is how many days a month, how many days a year were you essentially unable to really fully function in your ordinary life experience? And they measured that by health condition. And I'm going to show you a little bit what that looks like in terms of impact on health conditions in high income countries, including the US. Well, no big surprise, cardiovascular disease and diabetes are quite high. So we're looking at 30-ish days a year that somebody with these conditions on average is really unable to perform their ordinary life functions. Next one, maybe no big surprise, we have cancer at 37 days per year. And then really, to some extent, we were surprised, but then the other not, because I work with folks with these conditions. PTSD and panic disorder were the 2 single most life function impairing conditions out of any health condition in this major study that had tens of thousands of individuals being looked at. So one of the things that we talk about is that the impact of these conditions are really kind of under the radar and really not fully recognized in terms of the impact on lives, the impact on productivity, and the impact on health costs. Here are a couple of other metrics that are really quite significant. One is even pre-pandemic, we know that almost 20% of the US population in any current year is affected by anxiety conditions. But, only, around 37–40% actually do seek treatment for the conditions. Sometimes we get asked, why do we look at panic and PTSD together? Well, one is there's a lot of overlap between the conditions, really, again, not widely known. Most people with PTSD also have panic symptoms, which is really kind of the core symptom that we focus on. Another metric, as Mark talked about, emergency room utilization for people with panic attacks is about 5 times the baseline population. If you look into this literature, the rates of people who end up leaving the emergency room with a diagnosis of non-cardiac chest pain, palpitations, shortness of breath is extremely high. And when we talk a little bit about panic, I'll give you a little more detail about what that is like. But the other thing that's striking is how many of these people really go undiagnosed. Our company did a data analytic project with a major insurer, and we found that only about 20% of people that you would expect from epidemiological or population level data actually ever get a diagnosis for these conditions. So we see people who have kind of a general anxiety diagnosis, or they walk away with diagnoses of palpitations or other non-cardiac chest pain. So there are an awful lot of people who have these conditions that are really going under the radar, untreated or undertreated, or sometimes really overtreated in the medical sector. We'll circle back to that in a little bit when we talk about the healthcare costs of people who have these conditions, both treated and untreated. And Mark, CCHP worked up some cost data relative to these conditions.
We did, and when we shared that information with Freespira, we looked at 2 years worth of our adult medical and pharmacy claims, and first of all, look for those members, as Bob mentioned, that have been diagnosed with panic disorder and/or PTSD, and we found a significant number. Over 1,200 of our Medicaid members had a PTSD diagnosis, and another close to 1,000 had a panic disorder diagnosis. So again, that's out of around 150,000 total Medicaid members, but really out of about 60,000 adults in that program. So 2,000 out of that 60,000. And not surprising, as Bob mentioned, very consistent with that days out of role, these are expensive members. This is life impacting. The average cost of those Medicaid members, a little over $7,000 a year with PTSD, it's about 2 to 3 times more expensive than the overall cost of our adult population in Medicaid. PTSD is about 1.5 times more expensive than panic disorder. And so in the hierarchy, PTSD is a more costly diagnosis, exponentially more costly on the marketplace, where we're not paying Medicaid reimbursement rates, we're paying commercial reimbursement rates. And so again, but very similar ratios, about 2 to 3 times more expensive members with PTSD or panic disorder than our general adult population. A little smaller numbers, less than 100 on marketplace, less than 100 for both PTSD and panic disorder, but it is a much smaller population in total. We also looked at then those members that don't specifically have a PTSD diagnosis or a panic disorder diagnosis. Between the two populations, Medicaid and Marketplace, we had close to 40,000 members who potentially, based on their claims, could be impacted by these two conditions. So a really significant percentage of our overall membership that we wanted to focus on.
Thank you, Mark. We've been talking a lot about numbers and metrics and population level, but I want to tell you 2 stories about 2 individuals that I've worked with over the last couple of years. And I'm going to start by giving you a little sense of impact on their lives, really kind of what set the stage for these conditions. And then later, I'll circle back after you understand Freespira, what their response to treatment was. The first I want to tell you about is a young woman that I've known for a couple of years. And unfortunately, tragically, she lost her mother to breast cancer at about age 3. And as if that were not enough life impact, she ended up with a remarriage in an extremely abusive family context. And she developed PTSD. And a couple of characteristics of PTSD for this young woman, many times PTSD gets thought about as motor vehicle accident, armed robbery, military service, and combat. But this is a young woman who suffered through years of an abusive relationship for which there was really no escape until she went off to college. And what developed for her is that she was really kind of emotionally dumb, emotionally numb. Her emotions were not available to her. She was tremendously unconfident. She was tremendously protective of family members who had been through the same kind of abusive relationship. And what really, one of the things that really stood out is almost every night she had these traumatic nightmares that reflected back, 15 years history of this abusive family relationship. And in her experience, she would be in her dream. She would be unable to move, unable to protect herself, unable to protect her family members. So sleep disturbance was terrible. And there was a sense that this monstrous history was kind of living in her head. So you can imagine what it's like trying to navigate young adulthood and go to college when you're living with this kind of experience. So I'm going to set the stage really of kind of pre-treatment. And I have to tell you, based on our work so far with folks from CCHP, her story is not atypical by any means. The next is a very different person. This is an engineering professional, highly accomplished in his field, who in his middle ages developed sleep apnea, and which is not very well known, but not that uncommon. He also began to have nighttime nightmares, which we think were really associated with his sleep apnea. So he would again awaken in terror, probably stimulated by these apnea episodes. And his panic attacks then morphed into daytime panic attacks. His panic attacks then morphed into intense panic during airplane travel and intense terror when he was on a plane and there was any hint of turbulence. He would go into meltdown, which then morphed into his avoidance of travel. And so this was an accomplished business person who started walking out of TSA lines because he was so terrified on a business flight that he would have a panic attack during his flight. So you can imagine the impact on career, on self-concept, on work relationships, to have to call into a business meeting from the parking garage because he was unable to get on the plane. So I'm going to circle back in a little while after I tell you about Freespira, what we do and why we do it, kind of what the outcomes were of working with these individuals in my practice. But I really did want to make sure that we put a human face on this experience. So over and above the numbers, you really kind of got a sense of the impact on quality of life for people who have these conditions. So now I'm going to segue a little bit into panic and PTSD and why we do what we do. Both of these conditions, again, not really widely known. Most people think about PTSD as really caused by exposure to trauma, or panic attacks because people get freaked out about bodily experiences and such. Well, one thing that we really do know when we dive into the scientific literature is that there's a really important role of respiratory style and respiratory dysregulation. There's a concept called carbon dioxide hypersensitivity that's associated with these conditions. And a group of very, very smart researchers out of Stanford University about a decade ago started doing work in this, and they raised kind of an interesting question. If people's dysregulated respiration and their CO2 metabolism, their breathing style was in play, what would happen if you taught people how to breathe in a healthy way I have to tell you, there are about 20,000 apps out there that teach people how to do meditative breathing. But what they don't do is really measure physiology and teach people how to get command of their physiology. And so that's really kind of the core idea that Freespira grew out of. And that was to essentially detune this bodily reaction to respiratory dysregulation. And in doing so, the original research and a lot of follow-up research that I'll reference in a little bit shows that people who learn how to breathe differently during a short period of time really learn how to get command of their symptoms and have really significant symptom reduction over a long period of time by doing a relatively simple intervention that I'll describe for you in just a minute. But to give you just kind of a quick sketch of what the panic experience is like, is a high loading of physiological symptoms. So there are things like shortness of breath, chest palpitations, numbness, tingling, dizziness. No big surprise that people who are experiencing those symptoms go to the emergency room or to their cardiologist or their primary care doctor, because in their mind, they are experiencing a life-threatening medical crisis and not some stress-related issue. So that experience of these physiological symptoms is so intense, and people really have this sensation of they may be dying, they're losing control, they feel kind of spaced out and dissociated from themselves. So I have to tell you, if anybody out there has ever had this experience, you know how miserable it is. And if you've not had one, I hope that continues, because it is a profoundly frightening event that happens and tends to get to be recurrent and chronic. And people with PTSD frequently develop these kind of symptoms. What is a little bit different is that people with PTSD have these intense physiological symptoms when they're triggered by reminders of their trauma, whether that's in a nightmare or suddenly finding themselves in really crowded circumstances. And so they are flooded by the traumatic memories, but their body goes on overdrive. And so Freespira, I want you to think about, is a way that we teach people how to detune this really intense and horrible physiological reaction that's going on. So where do we fit in the landscape of how treatments are offered for these conditions? Psychotherapy and medications historically have been the two main approaches for treating these conditions. Mark has already talked to you about some of the access issues with CCHP, but we know that this is a national kind of dilemma. There are really challenges in terms of access to mental health professionals, and even more so access to people who were specifically trained in the treatment protocols that have the best evidence for success with these conditions. The treatments tend to be pretty well extended. 4 to 6 months to a year is not at all unusual. There are also really high dropout rates in psychotherapy, in part because the best research psychotherapy methods involve exposing people to what they're afraid of. And for many people, that's kind of a deal breaker. They do not want a treatment that starts off by scaring them when they're already scared. In terms of medications, antidepressants are commonly used. Benzodiazepines are commonly used, particularly for panic conditions. And complications are a high side effect burden. There are a lot of people who really can't tolerate these medications. The medications typically may take 3 to 4 weeks to begin to work. And many times medications need to be changed or dosages need to be adjusted. We also know, in part because of this high side effect burden, that a lot of people discontinue the medications. We also know from the literature that even people who are successfully treated, who stop taking a medication, will begin to have symptoms again. About 60% of people within 3 years who would really be considered, for all practical purposes, cured by a medication have panic symptoms again. We also know benzodiazepines, they work fast, but they're problematic. They're really only approved for short-term use, but they tend to be overused. And there's also a high risk of the development of abuse and addiction. And we know in both panic and PTSD that about 25% of these folks will also have a substance use condition, alcohol or other substances. And so that benzodiazepine use can unfortunately move some folks into abusive or even addiction cycles with these medications. We talk about Freespira. I'm going to get at some of the clinical evidence in a minute, but we do see very high improvement rates in a very short-term treatment. Our treatment is done in 28 days from beginning to end. The side effects are really very minor and transient, really sometimes to the first couple of breathing sessions. We are a completely virtual intervention. When we talked about the evolution of teletherapies in medicine, that there is no in-person encounter that's really necessary for anybody to undertake this treatment. We also know, and I'll share with you, very high compliance rates. People who start this treatment tend to do it to near completion. And we know that this is really a significant problem with a lot of other mental health services that are being delivered by technology. And this is what Freespira looks like. On the right-hand side of this slide, you see our system. It consists of a small respiratory sensor. This measures respiratory rate and exhaled CO2 levels. The patient breathes through a simple nasal cannula, and during a 17-minute period, their ask is really pretty simple. Their job is to breathe in sync with a rising and falling audio tone. In other words, we are trying to pace people's breathing, which tends to be fast and irregular. And at the same time, they are looking at a graph of their exhaled CO2 level, and their job is to adjust their respiratory volume so that they normalize their exhaled CO2 level. And it's this combination we know from the scientific literature and also from clinical use. This combination is really highly effective at reducing or sometimes even eliminating the symptoms of these conditions within a relatively short period of time. The system is recommended to be used twice daily, once in the morning, once in the afternoon or evening, 17 minutes per session. And the person is assisted by an assigned health coach who teaches them how and why to use the system, has brief follow-up calls over the next month that guide them through a successful experience. During that time, the system also ports all of the physiologic and adherence data as well as symptom data to our secure server. So our health coach can look at the patient's progress and to coach them in treatment so they maximize success. So a little bit, it's like if a doctor knew if they prescribed an antihypertensive that the patient took the pill last night, that they took it again the next morning, that their physiology was adjusting in the right direction, and their hypertension, they were measuring improvements over time. So in our own version, we are capturing all of that data on a session-by-session data so that we're really able to individualize the treatment, but also track response to treatment. So in a little bit later, Mark and I will be telling you about some of the metrics that we've learned from our first 6 months of work with CCHP. I'm going to give you a brief tour of the published research dealing with this intervention. And this is for people with panic-related conditions. 3 major studies that have been done. The original work that I described that came out of Stanford University, and then a program with 5 independent anxiety treatment centers around the country. And the other was with a major insurer and one of their major medical provider groups. And what this bar graph shows is that the people who enlisted in this trial had panic scores that were in the moderate severe to severe range, which means they were having frequent, intense panic attacks. They were very troubled by these attacks. They were afraid about when the next one was going to occur. And they were distorting their life behavior, for example, not taking public transportation like the patient that I alluded to, or they were not, not out in public, intensely afraid if they were ever called on, for example, to make a presentation in class. And so the average person enrolling in these trials had had this condition for over 10 years. The same metric, this scale, shows where this research group out of these 3 different independent studies ended up 28 days later. So this group went from scores of about 15 to about 5, and that's considered to be the remission level. In other words, if you score 5 or below, you're really not considered clinically to have the condition anymore. And really what was fascinating as I first became involved in this and looking at the existing literature, these people who were getting well within 28 days were remaining well a full year later. So we see these same clinical populations whose symptom scores are not only staying better, but in some cases even improving. And it's that duration of response that really first engaged me as a clinician. I have to tell you, I'm an experienced psychotherapist. I have yet to get somebody with severe panic disorder well in 28 days. So you can imagine my first experience of working with patients who had what really seemed to be kind of chronic and intractable conditions, really getting well in such a short period of time. And so for me, having both this published data and my own clinical experience of working with these patients is one of the things that's really been so compelling of working with this intervention. We talked also about the impact on healthcare utilization. The third of those trials that I talked about was with HIGHMARK Health. And we did a pilot project with their healthcare innovation group. And what they found is that the patients who enrolled in these pilots were really getting better at the same rate as the people within the other clinical trials. 73% of the people who took part were no longer having panic attacks at all a year post-treatment. But what was really different in this study is that HIGHMARK not only looked at their clinical improvement, but they looked at health outcomes. HIGHMARK measured any reason medical spending for these folks in the 1 year before they enrolled in this 28-day treatment and in the 1 year following. And what HIGHMARK was able to document was a 35% reduction in any reason medical spending, a 65% reduction in their emergency room costs, a 68% reduction in pharmacy costs. And it really is in line with that really churn in medical utilization. Many times these patients go from primary care to cardiology to psychiatry to pulmonology to neurology. I spoke recently with a physician, a psychiatrist, who finally diagnosed somebody with what I would call garden variety panic disorder, which means they had a perfectly healthy heart, who had had 5 cardiac catheterizations because he kept having chest pressure, chest pain, and the doctors kept looking for heart disease. And finally, after 5 cardiac caths, he was referred to psychiatry. You can imagine what the price tag was was for that case before it got to a definitive diagnosis. PTSD was really the next condition that was looked at for this intervention. And this is reflective of a study that was done at the Palo Alto VA. And instead of measuring panic conditions primarily, the researchers measured impact on PTSD symptoms. They used a scale called the CAPS, which is really the gold standard measurement of PTSD as well as treatment response to PTSD. And the researchers opened this up, interestingly, to both civilians and veterans. Combat exposure and sexual assault were by far the 2 largest sources of trauma. And at start, this group had a very high burden of PTSD scores. And immediately post-treatment, you can see this really striking improvement in their PTSD symptoms. But along with that were improvements in their panic symptoms, in scores of a measure of depression, the PHQ-9, an index of suicidality, as well as improvement in general life function, kind of similar to what we talked about, that days out of role. Essentially, the degree of functional impairment due to the health condition improved quite a bit. And this study went out to 6 months, and these declines in all of these symptoms continued to improve in the 6-month follow-up. So this was a really notable extension of the original work that the company had done with panic, to see that this was a treatment that could be effective for people with PTSD. And we know that PTSD tends to be a chronic condition and very, very significantly life impairing. We also know that living with panic and PTSD over the long haul, there is an accumulation of other behavioral as well as medical comorbidities that are much higher risk for people who have these conditions. And Mark, we're gonna look a little more at kind of the profile of these folks in your network.
Bob, thanks. And you can see here of the members that over the 2-year period that we measured, and those who were specifically diagnosed with panic disorder and post-traumatic stress disorder, we had over almost 4,700 members over that 2-year period. And the age profile is tending to be younger, from those adolescents to their 20s, This is a population that's going to stay enrolled in our plan for a number of years. We talked about the fact that they are high cost, much higher cost than our averages. And so they're impactable. And, you know, as we learned about the Freespira treatment over a 28-day period, this isn't long-term treatment. I think for a lot of health plans, we struggle with members who end up disenrolling. And, you know, how do you invest in their long-term health when you might only be covering them for the short term? Freespira really addresses that because it is a 28-day cycle, and we can tell very quickly if it's successful. So clearly a large percentage of our population, a surprisingly large percentage, actually diagnosed. And then as you see on the right, an even larger percentage, around 35,000 out of our members, almost a quarter, with potentially being diagnosed with unspecific diagnosis criteria. So this made a ton of sense for us to pursue.
You know, Mark, one of the things that when we look at this age distribution, I think your comment is really spot on. When we looked at those days out of role, metrics from the World Health Organization, heart disease and cancer tend to develop later in life, and they are tremendously life impacting. PTSD and panic, by comparison, are much more likely to develop earlier in life. Kind of the prime time, unfortunately, is between 17 and 25. And unfortunately, many people who develop these conditions end up with chronic conditions and the addition of these other comorbidities. And so we have this sustained impact on their lives and their productivity, starting at a relatively young age. And while there's certainly a lot of people who get better with psychotherapy and medication, there's a really substantial proportion that really don't get adequate response to other treatments. And so we also really think that if we can intervene early with these conditions, with safe treatments without significant side effect burdens that are affordable and can be readily distributed, that we have a chance of making an impact on these conditions before they become chronic and entrenched. So we're going to go ahead, Mark.
Well, as I said, we decided that we wanted to work with Freespira. We think this was a great alternative for our members, an alternative to that therapy and the pharmacologic treatment that's hit and miss. And so early on, about a year ago, I would say, right in the midst of the pandemic, we kicked this off. And we co-branded our education. We used multiple channels for member education, member awareness. We started in that first phase with letting all of our members, not just those diagnosed, but all of our members know about Freespira and our providers. So from the member side, we did emails, we did reminder, like kind of the automated reminder calls that we did to everyone. We did provider newsletters, and we put information on our provider portal. We want to make sure our providers are aware of this and the benefits of it for their patients. And then after that initial kickoff, then we focused on those members who were diagnosed with the panic disorder or PTSD via that claims analysis. So that was kind of the next phase, and we're now in that third phase as we speak today of outreaching to members with the related conditions or potentially related conditions. We initially targeted that we wanted up to 500 members to go through treatment, and can let you know that we've expanded that now, and we're looking at up to 1,500. It's been an amazing response from our members. I think it's one of those, good news, bad news. The good news is we've had an overwhelming number of members interested. That's also the bad news, right? That's that there are more people out there than we realize who can benefit from this. So I mentioned the provider education, also our case managers, our behavioral health case managers. This is a great tool for them when working with members that they didn't have before. And then all of our employees, we wanted to make sure that anyone talking to a member was aware of this, not necessarily to recommend it, but to maybe refer one of our members to our behavioral health team if they felt like this is something that they could benefit from.
Thank you, Mark. Really delighted to be able to give you kind of a snapshot of what our results look like to date. And this kind of circles back to when I introduced Freespira to you. Built in to our system are really the measurement capacities so that we can track at the individual patient level, but we can also report back to Mark and his team what response rates so that Mark, in terms of managing the health plan, is getting data flow about whether this program is effective. And at this point, we are 102 completed treatments in, and the average adherence is 71%. What that means is that somebody who starts using Freespira has done 71% of the recommended 56 sessions. And I have to tell you, for use at home therapeutics, that's a very, very high adherence rate. What I hear from my patients is most of them are experiencing subjective benefit within the first 7 to 10 days. And there's nothing like recognizable improvement that really promotes adherence. 71% also of these individuals had panic disorder severity scales that went down by 40% or more. This is really kind of considered to be in the literature a marker of clinical success, that there is a really noticeable improvement in life function, reduction in panic severity and frequency, and better ability to kind of live ordinary life. And then on the PTSD side, 50% of our participants so far have had a greater than 10-point reduction in their PTSD scale. So far we are very, very pleased with these, with these metrics to date. With that, I'm going to circle back to the two patients that I told you about a little bit earlier. So both of these were people that came to me, the first young lady with PTSD, the second with panic. And as I worked with this young lady, she had made a lot of progress, but the one thing that was not changing is that she was continuing to have these traumatic nightmares almost every night. And she did her Freespira treatment and really kind of stuck at it. And within about 3 weeks, the nightmares were lessening. They were not as intense. She was not as burdened by them the next day. She was able to go back to sleep. And what she told me, I hear over and over again, when she would begin to have a nightmare that was awakening, she would shift into this breathing style that she had learned. And the fear factor of this nightmare would really recede, and she was able to go back to sleep. And so I think we all know that quality of sleep makes a real big difference in quality of life. Second person, my guy who was walking away from flights, within about 6 weeks of his completing his 28 days of Freespira, he was on domestic flights again. And his confidence began to build that he could travel both personally and for business and really kind of master something that had been incapacitating for him. He was also engaging in I have to tell you, the amount of embarrassment he felt that he could not take his daughter to Walmart without sweating buckets in the car before he could steal his courage to go inside. That really began to ease. And within about 4 or 5 months, he actually flew internationally for the first time and made the entire trip without fear of getting on the plane and flying successfully. So I wanted to kind of bracket those experiences of a couple of folks that I've worked with kind of at the before and after stage. And we also have been able to take from our health coaches some of the experiences of CCHP members that we then report to Mark and his team.
Thanks, Bob. You see some quotes here that are just a small number that we've gotten back, some of those testimonials. This is information that as a health plan COO, I share with our entire team. It goes beyond the behavioral health team. I think this resonates with all of our employees, that we're doing something for our members that is making a dramatic difference in their lives. It's one thing to get them to the doctor for their appointment or for their immunization. That's certainly important for their well visits, But as you read these quotes, and I'll just read the middle one, I'm calmer now. I can do more things. I even went to a crowded spot for lunch with my wife last week, which I normally would have avoided. I'm getting out more, and I don't feel the need to avoid life the way I used to. There are more of these quotes that are dramatic, that we have impacted people's lives really positively. And the flip side of that is when you read them, you realize how much they were struggling, with day-to-day life. These are low-income families on Medicaid. They live with chronic stress. This is a huge issue. And to be able to provide this kind of solution with a 28-day treatment and this level of adherence is amazing. We've had almost 5,000 members contact Freespira in the call center looking for information about this. We've had about 1,000 go to their assessor to see if this is the right treatment for them. And that's within a matter of 6 months. So, this is something that we want to even scale up, as I mentioned, that we think there's a bigger role for this, especially now that we're starting to outreach to members who are potentially diagnosed, who haven't been diagnosed yet.
And Mark, we were going to talk a little bit about kind of, how you and CCHP have really kind of digested this experience. And, a couple of thoughts from you, and then I think we may have a question or two.
And the key learnings, I've touched on a number of them, obviously, that we have a high prevalence. And I think especially now, at-home treatment is becoming more common with telehealth increasing. And in particular for this population, you've got members who don't want to leave their home. And so, 3 times a week at their therapist isn't going to work. And that's why you see so many people starting treatment, ending treatment. So this really fits the population very well. And those outcomes that Bob shared that we're starting to see with high adherence rates makes this something that, we're going to see a positive outcome from a health standpoint. We're also going to see a reduction in cost because these are expensive members.
Mark, we have a couple of questions. One from Stephanie. What % of patients chose to use Freespira? And were there any barriers with access to devices and technology? There have been a few barriers. Technology has not made its full availability out to lower income folks. So we certainly do have challenges. We try to be adaptive. We have worked with some folks with smartphones and not with laptops and Wi-Fi. And our health coaches are very creative in terms of using phone and text and other methodologies to be able to train and stay in touch. There's really kind of certainly a minimum level of access to be able to, at least initially get a live face on video with a member, but we try to be flexible of there. And Mark, can you talk about the percentage of folks that we've had from outreach to then use? I think you mentioned about 5,000 initial inquiries.
Yeah, we had those 5,000 contacts. About 1,000 members went to an assessor, and then I think about half of those, about 50% of them, wanted to engage. So we're almost at 500 who are interested, and we're going to start the treatment up with. So it's about 50% of those who this was a fit for, and Freespira handles that assessment, that making sure this is the right treatment for an individual. They talk with them on the phone. I did want to mention one of the barriers that we are experiencing is the return of the equipment. And while Freespira does a great job to provide a paid return box for members to return them, CCHP is on the hook for those costs. And so we got to make sure that device gets returned. We're actually going to be implementing some incentives. Incentives tied to compliance, tied to filling out some surveys afterwards. We value the members' input, so we'll put some dollars around some of those post-treatment follow-ups, and then we're putting some dollars with that return. So modest amounts, but yet I think if we attach some, we may see a little better compliance rates.
We also had another question. One viewer actually is not viewing, can only see panelists, but not the slides. We will make slides, and the recording will be available to members. And I think Ron is putting an answer in that, but we'll certainly facilitate giving you access to both the presentation and the slide deck. We are certainly working on, the technology challenges. We talk about the creativity that's really necessary sometimes. One of the things I do want to emphasize is the users don't really need to provide anything of their own. The system comes with a tablet computer with the sensor, all the necessary equipment. And we send out a tablet for a couple of reasons. One is that somebody may not have their own, but we also want to use something that's not going to have text messages and emails coming on to distract them from their treatment. So it's really a self-contained, really pretty easy to use. And for people who will make that commitment of practicing regularly, it does make a real difference.
We do have another question if you'd like. Do you have more information on the PTSD members, demographics, clinical indicators, et cetera?
We are in the process of looking at that now. It's really not available to use. Actually, I have a paper in preparation that's really going to be looking at our panic versus PTSD. One of the things that we do find is that there are a pretty fair number of people who end up being identified as having panic conditions, and as our health coaches talk to them, realize that they have been significantly traumatized. So there's really a lot of crossover. And what we see in the demographics are people who range from a single dramatic event to people who have had relatively lifelong and chronic traumatic exposure. We're still learning a lot about PTSD, and so we're hoping, actually there's a paper in publication about our PTSD, but unfortunately I don't have anything more specific to share with you about our PTSD demographics, except that their response rates are really, quite good and pretty comparable to what was done in the formal research.
Okay, well, it looks like that takes care of our questions for today. With that, I'd like to thank all the attendees for taking time out of their schedule to be with us today. And I'd like to thank Bob and Mark for a very informative webinar. Just a reminder that the slide deck and recording will be posted on the ACAP website by tomorrow morning. So thanks for your time and stay safe.
Thank you, everyone. Thank you, Ron, for hosting us.